you see that? Right. Good afternoon, everybody, and thank you for joining us this afternoon for our Meet the Coroner with a pressure ulcer focus, because obviously this week is Stop the Pressure. So we're going to have a session for the next sort of 2.5 hours with myself. So I'm Sam. I've been a tissue viability nurse for 15 years. I've worked in an integrated trust covering both acute and community services, and a big focus of that role as a tissue viability nurse is pressure ulcers. I'm also joined with my colleague Charlie, so she's going to man the chat. So any questions, comments, please put them into the chat box and Charlie will answer those. The format for the next 2 hours or so is I'm first of all going to go through the importance of your documentation, really key, and so we're going to explore that for the first sort of 45 minutes, and then we're going to have a much more interactive session after that. So we're going to have some videos that we're going to play. In between the videos, we're going to have an opportunity for some chat and interaction, and you'll get to play the part of the coroner to come up with your final conclusion or verdict on what you think the outcome of the case is. So I hope you really enjoy the next couple of hours. So the importance of your documentation. And when I do this presentation, I always think of that first day for myself when I started my nurse training. And there was one thing that we were told, and that was, if you didn't write it, it didn't happen. And this is going to be a common theme over the next 45 minutes, because your documentation is your evidence of the care that you've given to your patients. And it's really key that you make it as accurate and as clear as possible to give your rationale for why you're giving the care that you give to your patients. Because unfortunately, some of you attending today may have been called to a coroner's court, or maybe in the future you may be called into a coroner's court, and it's vital that you've got that documentation to stand you up and provide that evidence of the care that you've given to your patients. So it's Pressure Ulcer Week today, isn't it? So stop the pressure. The theme this year is inclusivity. And I actually went on the webpage before I started this today, and it's about making sure that we're providing resources, having conversations with our patients, and ensure we're doing it in a language and a format that they understand, so they're included, so they're not so they're able to follow instructions, follow advice that we give to our patients. So I just wanted to share that part before we start really looking into this presentation. So some of you are going to be from all different care settings, acute, community, nursing homes, residential homes, and you're all going to be working with people, with patients. And it's really important that you understand what a pressure ulcer is, and what we can do to prevent them. We always know prevention's much better than cure. So here's the definition of a pressure ulcer. So it's that localized damage to the skin and the underlying soft tissues. It's usually over a bony prominence, but it can be anywhere on the body, because it can also be related to medical devices. But not only that, it can be related to unusual objects sometimes. So I always remember there was a gentleman when I worked in community, and he had this real necrotic area on his thigh, and we couldn't work out where this damage had come from. But this gentleman was actually bedbound, and he had a walking stick, and he used that to change the channel on his telly. And once he had done that with his walking stick, he laid it next to him, and then he laid on it. So sometimes some areas of damage can be quite hard, and you have to be a bit of an investigator and find out. But usually pressure ulcers will present over those areas of bony prominence, and thinking about those medical devices. Also oxygen tubing, masks, they can all cause damage. So many nasty category 4 pressure ulcers on sort of that nasal bridge. So really doesn't take a lot of time for that to really break down to the structures. So pressure ulcers can present as intact skin or as an open wound. They're painful. If you nursed a patient with a pressure ulcer. They're really, really painful for them. And that's often your first indication that something's happening, that something's not right. The patient will say, for example, my heel feels really sore. Can you take a look at it? That should send those alarm bells. Something's not right. They can occur as a result of that intense or prolonged pressure, so staying in the position for a long period of time. And also as a result of that combination of shear. So that shear forces, it pulls the tissues and causes that damage, often to the deeper structures. So that's when we look at that picture, unfortunately, patients do end up with that extensive damage to them if their pressure areas aren't looked after properly, and if we don't do the interventions to stop that damage from occurring. And this is just some of the impact of the pressure ulcers just in the UK. So over 1,300 new pressure ulcers are reported each month, affecting over 200 people annually in the UK. But these are the ones that are actually reported. There are going to be many, many patients at home that aren't really aware of what's happening to their skin, not aware that they do have damage, or are too scared to go and get any support or help because they don't want to either contact the GP, they can't get into the GP. We know that there's a real issue with patients being able to get to see GPs at the moment. So they most probably just think, oh, it's nothing to worry about, I'll just wait till it's better. And over COVID times, I remember a lady I went to go and see at home, and she had phoned up, and as a community nurse, we went to go and see her, and she'd actually got rolls and rolls of kitchen roll, because her bottom was weeping and she'd sort of packed it up. And when we got there and actually removed all that sodden, solid, hard toilet roll, she had an extensive category 4 pressure ulcer, but because of where it was, she couldn't review it, couldn't see it, and she just kept putting more and more of this toilet roll, kitchen roll there. So it's really, really important that that lady had actually seen other people but hadn't highlighted the concerns or hadn't been asked how is her skin, and there were some missed opportunities for her where she could have potentially got some help sooner. Pressure ulcers are the single most costly chronic wound to the NHS, accounting for up to 4% of the UK healthcare budget. So that's 2.1 billion a year. So, it's very, very costly, pressure ulcers are. In monetary terms to the NHS, we know that the NHS is struggling. We haven't got enough money. There are budget cuts happening everywhere, but we're spending 2.1 billion on a wound that potentially most of the time is unavoidable. Pressure ulcers in older patients are associated with a 5-fold increase in mortality, and in hospital mortality, this goes up to 25 to 33%. So that's a really scary statistic. If you've got a family member, or if yourself, you're admitted to hospital and you end up getting a pressure ulcer, you're 25 to 33% more high risk of ending up in mortality. Really, really scary statistics. So we need to do everything we can to prevent this pressure damage happening. And that's why it's really important we do these national awareness days, to bring that awareness to everybody, that everyone can support, everyone can be involved in pressure ulcer awareness. And it's about sharing this message around and making sure that we're educated and trained to be able to manage these patients. So we've got the pressure ulcer clinical recommendations for the National Wound Care Strategy. So these were updated, and there's some changes to the categories. First of all, wherever you work, follow your own works policies and procedures. Some trusts have adopted these new guidance, some haven't. So it's really important that wherever you're working, you work to the guidance that's within your own areas. But the updated recommendations are that pressure ulcers are categorized 1 to 4. So you've got your category 1, which is your intact skin, your category 2, that's superficial skin damage or intact clear fluid filled blisters, your category 3, where it's down to full thickness. Sometimes there can be undermining, and then your category 4 that's down to the deep structures. There used to be unstageable, and again, if you're still using the terminologies and you're still reporting unstageable, carry on in your normal way. But what the new recommendations say, that if it's categorized as what would have been an unstageable, it should then be initially recorded as a category 3. But once that slough, necrosis, or anything that's obscuring the depth has been removed, you would then recategorize. And if it was a category 4, you would then recategorize as a category 4 if needed. There are also, within the new recommendations, they've taken out the deep tissue injuries. So they shouldn't be recorded as pressure ulcers unless they result in broken skin. Again, follow your own local policies and procedures, but it's just to make you aware. And if you are following these new recommendations, then just so that you know that the deep tissue injury has been changed to only be reported if the skin's broken. This just illustrates basically what I've just said. So you can see in that first image, that category run, you can see it's that sort of erythema. Really important to be aware of dark skin tones as well, because that area of damage can be harder to identify. So you need to look at other ways of identifying unusual skin changes within those vulnerable areas. So it might be that rather than having that red area, it might look slightly paler. There might be slightly warm to touch around that area. Again, listening to your patients, if they say that it's painful, something's happening there. So we need to be putting interventions in to stop that damage from continuing. Then you've got your category 2, superficial skin loss, or like I said earlier, that clear fluid filled blister. They're your category 2s, and then we're going into the deeper structures now. So our category 3 is full thickness. So we're down to the epidermis and the dermis. We've got more depth to that wound. Sometimes they can undermine. Again, just need to make sure we're doing that really thorough assessment. And then your category 4, where it's down to those deep structures. So there might be bone visible, tendon, and that's your category 4. And then the 2 highlighted in sort of I would have said orangey red. So they're the ones that are removed if you're following the new National Wound Care Strategy recommendations. So that's your unstageable that would now be categorized as a category 3, and your deep tissue injury that unless that skin is broken, you don't need to record, but you obviously still need to put your interventions in. If you've got a DTI on a heel, you need to be offloading that. You need to be looking at the equipment that the patient's on, looking at their repositioning regime. So you would still instigate all that care and that intervention, but you don't need to record it through your normal channels. So this was taken from NHS resolution. So you can go on there and have a look at the webpage. It's quite interesting if this sort of thing interests you, but it was just shows you about sort of that litigation surrounding pressure ulcers. So the NHS resolutions is a department of the health, and they provide indemnity to the NHS for risks involved in delivering healthcare services. So any sort of litigation, it would go through to the NHS resolutions, and they would then complete a report, look at the incident and see if actually the NHS was at fault or some omission in care happened, and then they would look at recompensating that patient for what had happened to them. So in 21-22, the total payments that were paid by NHS resolutions was 2.4 billion. So again, if we're looking at the cost to the NHS of 2.1 billion for the treatment of pressure ulcers, we're actually paying out more money for compensating patients that have been caused harm. So the total NHS budget is 199 billion, which, you know, it's unfathomable. You can't imagine how much that would even look like in your bank. I mean, I'd like to, but we can't actually, you know, imagine that amount of money. But how much of that is being wasted on wounds that are most of the time avoidable, and then we're paying for the litigation on top of that. This is another statistic. So, I mean, it's quite old now, but in between 2010 and 11 and 2019-22, there were 1,781 claims relating to just hospital-acquired pressure ulcers. So this is just in the acute trust. And to resolve just 15 of that 1,781 claims, it was at a cost of £292,000. So that was just to settle 15 of those claims. So, and I expect these are still going on because it takes a lot of time to go into the investigations and review all the notes and look at all the claims. So it's a constant cost to the NHS. This again came off NHS resolution. So it's an illustrative story. And again, you can go onto these web pages and you can find lots of information. But it's just a really good way of illustrating what happened to a patient. So this is a patient, I'm just reading off my notes because of the detail. So he was in a care home and he attended the emergency department at midnight following a fall. And he was classed to be a level 3, so he should have been seen in an hour. But actually the doctor didn't get to assess him for 6 hours. It was decided there was no significant injury and to admit to intermediate care. There was no beds, so he waited on the A&E trolley for 16 hours, 45 minutes. A Waterloo was completed and he was deemed to be high risk. So they put him on a Biflex mattress, but no skin checks were carried out. He was given food, no toileting and no drink. He was incontinent and there was very, very limited documentation about his comfort rounds. Whilst he was in there, he acquired 4 pressure ulcers. He had a Cat 2 and a Cat 3 to his sacrum. And then he had further pressure damage to his heels. And his case was successful and he was awarded damages because although he was a Waterloo was completed, no skin assessment was completed and no body map was completed. There were significant gaps in the nursing documentation. The nutrition review didn't happen in the emergency department. And there was no 2-hourly care and comfort rounds because the documentation wasn't completed. And he wasn't adequately repositioned on the trolley. So he was awarded damages because not all elements of care were provided despite identification of risk and pressure aids provided. He did not receive level of care expected of a competent practitioner. So he was awarded damages for this. So then when we look about the actual impact of pressure ulcers on patient, because we talk about the cost to the NHS, but actually for me as a clinician, it's the cost to the patient that really drives home this message, because pressure ulcers can lead to severe disability, such as amputation. If you think about your patients that have compromised circulation and they're then put onto a mattress or a bed or they're immobile for a period of time, doesn't take long for that tissue on the calcaneus bone to break down, and then they end up with extensive pressure damage to their heel. They haven't got that blood supply to be able to heal that wound. Then they really are at high risk of amputation. Our diabetic patients, again, really high risk. And you think about if a patient has to end up with an amputation, what does that do to their quality of life? How does that impact their life moving forward? We know we're seeing patients much younger now that could interfere with their work life, with their family life, with their hobbies. We know, depression, it has this knock-on effect for the rest of their life if they end up having an amputation, for example. They sometimes require extended hospital stays. They might require theatre. If they've got a really extensive pressure ulcer, they might have to go and have it debrided in theatre. Where I worked, it was at a spinal unit, and we had patients repatriated over from all over the world to come and have really extensive operations for pressure damage, where they had to remove large areas and then do flaps and all sorts to manage and make that better for the patient. They can result in infection. And we know, don't we, with the antimicrobial stewardship and what infection can cause. The International Institute of Wound Infection estimates that by 2050, that we're going to have an additional 10 million deaths a year due to antimicrobial resistance. So again, we need to do that prevention. That prevention is key. Osteomyelitis, so that infection in the bone, how are we going to get rid of that? Again, it might need further surgery. It may need prophylactic antibiotics. So what does that do for their resistance moving forward? They can be life-threatening. Patients die from pressure ulcers if they become get sepsis. If they're really, really unwell and they haven't got that that immunity, they can end up dying from a pressure ulcer. And like I say, they can result in that need for surgery and prolonged periods of forced immobility. Like I say, where I worked at a spinal unit, some of the patients have been on bed rest for months and years because the policy was in there that whilst their skin was broken, they were unable to get out of bed. So can you imagine just being on bed rest for years due to a pressure ulcer and what that would do to you mentally? So now we're moving on to the patient safety incident reporting framework. So this replaces the serious incident framework. So this is been adopted by most trusts now. When I do this teaching, most trusts are now using this format to do their reporting. So the patient safety incident is reported on the clinical system. It then needs to be verified by a clinician deemed appropriately trained. So within our trust, every DATEX that came through was actually reviewed by a tissue viability nurse. But I know in other areas where I teach, it might be the senior leaders or tissue viability link nurses. But somebody that has that training and understanding needs to ensure that that category is what it has been reported as. The next stage is looking at that compassionate engagement and involvement of those affected by the incident. So it's about that communication piece, isn't it? It's talking to the patient, it's talking to the family, it's talking to the staff that have been involved in that incident and getting the information and communicating openly and honestly. Being open with the patient and the family and carers, explaining what has happened and what the outcome of that is for the patient, whether it's a significant impact moving forward or whether it's minor. It still all needs to be communicated to the family and patient. Then you look at the application of a range of system-based approaches to learning, and this is how this framework is so much different. It's about the learning. We need to learn. We need to reflect. We need to share that learning with our colleagues, with our teams, to make sure that everybody's learns from it and can change their care to stop it happening again. And that's really, really important, because that's what we're always trying to do. We're just trying to improve services and improve our care so that patients don't get harmed. And then you do the considerate and proportionate response to the patient safety incidents. And then you make sure that it's recorded and it's shared within your trust, your areas, and anyone that it's relevant to share that with. Because if harm does happen, there are possible consequences. We work in the public sector, we work with people. And if things go wrong or if care's not appropriate and things happen, there are going to be consequences. And these are just some of the examples. So obviously the coroner's inquest, that's what we'll be mostly focusing on today with our videos this afternoon. You may be called to a coroner's, and we'll go into that into more detail, but it's a legal requirement that you go. There may be a public inquiry. You may have disciplinary or capability hearings or be called to the NOC for fitness to practice, civil claims, employment tribunals. So or you might end up in the court of protection or magistrates, Crown Court. You know, these are, we have to be realistic. These are the possible consequences because we work with public, we work in the public sector. And that's why we need to make sure that our documentation and what we do for our patients is adequate to be able to stand up and evidence what we've done for these patients. Because we're accountable. As a professional, you are accountable for the actions and omissions in your practice. It's down to you to have the knowledge, the skills and the training, work within your competency. We sit on the register and we know the NMC code of practice for those of you that are registered nurses. For those of you that are not maybe in the register, you're still accountable for your actions. As nurses, as healthcare professionals, we make judgments and we use our own professional knowledge and skills to make that decision, to decide what's going to be best for that patient. But we need to be able to document that and evidence why we came to that rationale. And whether that's working in any healthcare profession, what you do to the patient has to have that rationale. You need to be able to justify the decisions you make. And this is where your documentation should support those decisions you make. This is a professional duty of candour. So this was a legal requirement back in 2014. And I was a tissue viability nurse when this first came out, and there was a lot of fear around it. People felt like there was going to be more litigation. People were going to blame them individually because they had owned up as such, to say something had happened, that something had happened with the care of either that patient or if they were talking to family members, because it's about being open and honest when things go wrong and giving that apology. And it is vital as health and care professionals that you understand that it is really, really important to be open and honest with service users. And actually what happened in our trust was, although there was a lot of fear around doing the duty of candour, we found that our complaints came down massively as an organisation because it had that conversation, it opened that communication, and actually having that really open and honest conversation where you say, you know, this has happened, but this is what we're going to do, and we're going to investigate it, and we're going to keep this communication going between us, and we'll let you know what the outcome is to ensure this doesn't happen to somebody else. Actually, that's what most people want to know. They don't want to sue you or take you to court or anything like that. They just want to make sure that it's being looked into and that you're going to learn from the lessons from the investigation, and it's not going to happen to another person. So like I say, it was actually a really a good piece of work, I think, and it really supported us in our trust when we used it. So moving on to the role of the coroner. So like I said, in the next part of this session, we're going to be looking at some videos where we've got a coroner's court. And this is what the role of the coroner is. It's limited. So his or she's role is determining who the deceased was and how, when and where they came by their death. When the death is suspected to have been either sudden or unknown cause, violent or unnatural, the coroner decides whether to hold a post-mortem and, if necessary, an inquest. So that is the role of the coroner, to find out how, when and where that patient came by their death. Sometimes there might be a pre-inquest hearing. If a full inquest can't be held within days of the death, the coroner will open the inquest at a short hearing called a pre-inquest hearing. And then the coroner will decide how long that inquest is likely to last, and also whether a jury will be needed. Most of the time in a coroner's court, you won't have a jury. Then the coroner's inquest is a legal inquiry into a death. It's held when the cause is unknown, violent or unnatural, and it can be held in public. So It's been on my to-do list for a long time, but if you go to your local council, there'll be a court, and you can attend the court, and there's always a public viewing area, so you can see the process. Like I say, it's usually held in public. Sometimes they won't if it's to do with children or a very sensitive case, but on the whole, you're able to go and view in public. So if you're called to the coroner, it's a legal requirement. You don't have the opportunity to say, oh, I don't fancy that, thank you, no, I don't want to attend. You legally have to go if you are called to the coroner. And they will expect you to answer their questions as accurately as possible, and you are under oath. For those of you that are working in trusts, like NHS trusts, if you were ever called to a coroner's inquest, you will have a legal team within your trust that will support you through this process. And again, I think even if you're in the public sector, there will be support around to help you if you are ever called into this. I don't want to make everyone petrified, but I think you need to be aware that this is a possible consequence because of the nature of where you work in that public sector. It's not about apportioning blame. It's just finding out the facts and finding out what's happened. And if you're called to the coroner's court, you will have to rely on your records to support answering those questions. You can be called up to coroner's court years after an event. And if you're anything like me, even if I'm asked what I did last weekend, I can't remember. It takes me a long time. So there's no way I'm going to remember a patient that I saw 2 years ago and what care I gave them and what my rationale is. So I would only be able to rely on what was written in the notes. You should only state the facts when giving the evidence. So if you haven't got it written down and evidence somewhere, don't try and sort of think, well, I'm sure I would have done that, because if you haven't got that evidence, you haven't got that record, then you can't say what happened, because if it didn't write it down, it didn't happen. And if you don't know the answer to a question, you just say, I don't know. You can't just make things up. Like I say, it's got to be factual and it's got to be accurate. These are the possible, it says here, facts, verdicts or conclusions that the coroner might come up with after an inquest. So some of them are self-explanatory. So natural causes, normal development of a natural illness, not significantly contributed to by human intervention. So quite self-explanatory, natural causes. Then we go on to accidental death or misadventure. So this is where the cause of death was unnatural, but not unlawful. Deceased has taken a deliberate action that has resulted in their death. So I often think about that sort of accidental death. So for example, this morning it's quite icy, and sometimes people think that they will go on an icy lake, or you sort of see reports and in the news of children that have maybe gone onto an icy lake, and then that ice is broken and they've gone into the water and they've not been able to get out and they've unfortunately died. Well, that's an unnatural death. Is accidental death. So that's just an example of that sort of that misadventure, and that could have been a conclusion for an example. Then you've got unlawful killing, so murder, manslaughter, infanticide, serious driving offences, suicide, so where the deceased has voluntarily acted to end their life in a conscious way. Neglect, so gross failure to provide the deceased with basic needs. And then finally, you've got this narrative. So that's where the coroner sets out the circumstances of the death in a detailed way based on the evidence heard. And then we move on to our Regulation 28. So after an inquest, the coroner can write a prevention of death, future death, or a Regulation 28 report. And this happens when the coroner has heard evidence that further avoidable deaths could happen if prevention action is not taken. The report is sent to the personal authority who have the power to make those changes, and they've got 56 days to show how they've made those changes and what they intend to do. And what I did this morning was actually went on and just found a up-to-date sort of regulation 28 that's been issued. So this was actually issued last year, and I think this just illustrates really nicely about a regulation 28. So I am going to read off here. So this is relating to a patient that was admitted to hospital. He had a medical history which included poorly controlled type 2 diabetes, peripheral vascular disease, ischemic heart disease, and chronic kidney disease. He had also undergone amputations of his toes due to non-healing diabetic ulcers. And this gentleman, he had a fall at home. He said that he'd fallen forward and onto his knee. He was lifted from the floor and onto his bed by his family, where he remained until an ambulance was called. The decision was taken to admit him to hospital. He was admitted via the emergency department, then onto the medical assessment unit. Just get rid of that. Initially admitted with the diagnosis of right knee septic arthritis and an acute kidney injury. He was on antibiotics and he had a washout of the knee, but whilst he was in, he obtained a pressure ulcer to his sacrum, and this actually ended up being the biggest source of infection. The pressure ulcer was getting worse, his inflammatory markers were going up, his testicles became swollen, and there was a suspicion that he was now getting Coroners gangrene, and then a referral was made to the urology team. The orthopedic surgeon said that as far as the treatment for the knee went, he felt that they were winning and that it was improving. And if he hadn't developed the pressure ulcer, his expectations was that he would have been discharged. So like when we were talking earlier about what the impact of pressure damage can do, and that further long stay in hospital. So this patient should have gone in, had his knee washed out and been discharged, but because he sustained a pressure ulcer, he was becoming more and more acutely unwell. He had this significant infection from the pressure ulcer to his sacrum, and it was all agreed that surgery wouldn't help. So sadly, after discussions with everyone, he was deemed not fit for surgery, and he was placed on priority of care and died. So the coroner who listened to this case came up and actually issued a regulation 28 to this hospital. And this is what she said. There were many concerns. This pressure ulcer was preventable, that it was that basic nursing care that wasn't achieved, that once it had developed, the pressure damage had developed, if he had had good skin care and the S-Skins bundle had been followed, the damage would have been minimized. And then she goes on to just list everything that happened. So I'll just go over it because I think it's really, really important. And it just, while I'm going through this, I just really want you to reflect on your own practice and think, could this happen in my clinical area? Could this happen where I'm working? Are our processes and our paperwork up to scratch? And it's just a reflection, a self-reflection. So he didn't have a sacral pressure ulcer when he was admitted to hospital. The first time the sacral pressure ulcer was mentioned in the notes, a TVN referral was sent stating for deep tissue injury to buttocks with blistering, stating the area appeared overnight. The screening tool score for him came out as not at risk of pressure ulcers. This was wrong. He was at risk due to his immobility, diabetes, which increased the risk of pressure damage developing. In addition to his age and his medical history, he should have been scored high risk. Because of this, nothing happened, and it should have. He should have been on an air mattress, and he should have been repositioned regularly. On MAU, so the medical assessment unit, he didn't have a risk assessment done within the 6 hours as it should have been. When he went up to 2 days of his admission without any air mattress, so he wasn't on an adequate mattress for his needs. Once recorded as high risk, he should have been reassessed every week. This was not achieved. The skin bundle, a nationally recognised tool with care plan, was rarely completed, and when it was poorly completed. Skin assessments should have been carried out daily. When they were carried out, they were ad hoc and inaccurate. Sometimes skin was recorded as normal when it clearly wasn't. On one occasion, a body map was circled indicating the areas of concern, which was the sacrum and the left heel, but lacked information and categorization. Of significant concern is the fact that he spent long periods of time on his back with little or no evidence of offloading of the sacrum or heels at all. He should have been repositioned every 2 to 3 hours during the day and between 2 to 4 hours at night. There was no structured repositioning at all. It was estimated that every day he was in hospital, he was on his back for 22.5 hours, and there was no sustained time off his sacrum, and there should have been. When he was sat in his chair, there was no evidence that he had an air cushion to sit on, and when sat, he should have been stood hourly. It was raised that there was a query of his own compliance, but there is only 2 occasions when he declined to be moved. There was no evidence of use of 2 sliding sheets to assist him with moving. Podiatrists who raised concerns about a new area on his right heel completed an incident report. This should have been managed and picked up by the nurses in their daily checks. In addition, he should have had pressure relieving boots to prevent this, and there is no evidence they were used at all. Fluid balance charts were poorly completed. He wasn't weighed, which would have assisted with managing his edema. Appropriate nursing care was not achieved, and pressure care was a fundamental part of nursing care. So she put, I have advised that the trust have not taken significant steps to reassure that this won't happen to anyone else. And this was only last year. So this case was only last year. So this is still happening. It's still in the healthcare system. And I just think it just really highlights lots and lots of issues and failings for that patient, and just to reflect on your own practice and what you record, because it needs to be detailed to be able to support the care you give. So moving on to record keeping. It's part of our clinical governance and to ensure that we keep good, accurate documentation. Record keeping is an integral part of nursing and midwifery and allied healthcare professional practice. It's not to do if I can, if I've got enough time. It is an essential provision of safe and effective care. So you have to do your records, and to do them as close to the time that you've carried out whatever you've carried out. It's not something you do at the end of the shift and quickly get a pile of notes and just scribble some quick notes in. It's a legal document that can be called into coroner's court. So you need to spend the time, make sure it's accurate. We're not asking for war and peace, but you need to get those key elements into the record and into your documentation. Records can also include anything that makes reference to the care of the patient, and any records can be used or be called upon as evidence. So this applies to all forms of records. So for any of you that are still using paper records, I think there's less and less now paper records, but they would still be called in if you're using a variety of both. Any emails that are sent between yourself and other healthcare professionals, family, anything can be called in. Handwritten clinical notes, letters to and from healthcare professionals, care plans, wound and risk assessment forms, photographs. We're really lucky now that we can use photographs. Within acute trusts usually have medical photography. Out in community, there's lots more IT. You've got laptops and phones that you're able to take the photos. Photos give so much detail about wounds, and it's really, really important that if you have the facility to take photos, that you use that and do it regularly, because it will show you if a wound's progressing or deteriorating. And again, these can be called in as forms of records of evidence if you're called in somewhere. Lab reports, x-rays, telephone conversations. So as a community nurse, I used to always have a pad and paper because it usually happened that you'd be driving somewhere and you'd have to pull over to take a phone call. But I would always make sure I documented the time I took the call, who I was talking to, and the key elements, so that then I could record it when I got back to the office. So I had it written straight at that point, because otherwise, as soon as I'd driven off, I'd have forgotten that conversation or the time that I'd had that conversation. So really think, is there a way that you can improve your documentation? Are there things that you could actually do a bit better? Because if it is not recorded, it didn't happen. And that's the black and white of it. If it's not recorded, it didn't happen. Careful and accurate records may assist if you're defending claims of negligence. I'd also suggest, if you've got any colleagues where their notes, you read them and you always think, oh, that looks all, I really like the way she writes her notes, or I really like the way he writes his notes. They're always really clear and they get all those key parts in it. Reflect on that and think what they do that you want to emulate in your records, and do that as a bit of self awareness, self-reflection, to make sure that you are capturing everything you need to, because these are some of the common problems that are seen. As a tissue viability nurse, I was involved in lots of incidents relating to pressure ulcers, and these were very, very common themes that came out of those reports. So that absence of clarity, failure to record action taken when the problem was identified, failure to escalate, so not escalating. If the wounds deteriorate or the pressure areas deteriorate, and have you escalated? Have you let your tissue viability nurses know? Have you escalated to another specialty if you need additional help? If their nutrition isn't optimized, do you need support from your nutritional team? It's looking and making sure that you've got the support of other specialists as and when needed. If you've ordered a mattress and it hasn't arrived, have you escalated that? Have you let the mattress company know? Have you found out when it is due to come? Missing information. So one for me, and I expect quite a lot of you are now using Purpose Tea, but we used to have the Waterloo, and whenever we did any investigations into pressure damage, one of the common things was that the Waterloo assessment was only half filled. So they usually just filled out the left-hand column, and the right-hand column was often missed out. So again, that risk assessment isn't complete. Therefore, you're not identifying patients that would have been high risk because you're not getting all those scores correct. Missing and inaccurate wound measurements, really, really important. Most dressing packs all come with the little tape measures now. You need to measure wounds accurately, because the next person that comes along, if they think, oh, well, last week that was 2 by 3 centimeters and now it's 5 by 8, that's deteriorated extensively. But actually it's because somebody's estimated the size of the wound. And inaccurate information. Anything you document, it has to be factual. This is just some examples of, again, some common issues found in patients' records. So leaking plus, or leaking plus. What does that actually tell you? Because your leaking plus could be what I think is leaking plus. So really think how you can make that much more accurate, much more detailed, and give more factual information. Dressing intact. What does that tell me? How long has that dressing been intact? When was the dressing put on? Is there a big gaping hole underneath that dressing that was put on there just in case? Skin intact, but you can still have deep tissue injury. You can still have damage to the skin even though the skin is intact. All care given. What care? Have you got care plans? Does that relate to care plans? It needs to be more detailed. Mattress ordered. Great. Mattress ordered. What mattress? Why is the mattress ordered? What time was the mattress ordered? What time is it due to come? That additional information is really, really important. Ordered number as well, so that if a colleague needs to chase it up because it hasn't arrived, they've then got the order number to be able to do that. Patient repositioned. Well, repositioned where? On their left side, their right side, into the chair. We need the detail to be able to know what's actually happened. And we often talk about just adding these 3 little words, and it's just adding that extra detail. So like I say, when you go back to practice, just look at your notes and think, is that saying everything I need to say, or do I need to add that extra detail in? So instead of just sacral red area red, what else can you put? Is it non-blanching? That gives you so much more information. Category 3 where? And like I always said, in our trust, we had these magic wounds, because 1 minute it would be on the left heel, then it would magically go on to the right heel, because people weren't getting their lefts and rights confused. So it's really, really important to be accurate. Skin vulnerable. Why is the skin vulnerable? What are you going to do to optimize the skin to not make it as vulnerable? 3 hourly turns. Why 3 hourly? What's your rationale for doing that? And there's some more examples as we go along. So that is our first part, the importance of your documentation. So I'm just going to go over to Charlie and see if there's been any chat, anything going on before we go on to the next part.
Yep, so just some of our Scottish colleagues have joined today, and so they're just been updated. They're not allowed to use their mobile phones to take out pictures of patients, but there's an app that they use, and then some do have an agreement with the medical photography team where they can take them on their mobile phones, but then they are uploaded by the medical photography team.
Okay. So I know follow your own policies and procedures in your own areas, but taking them on your own personal one, you just need to make sure that there are things in place that to safeguard you, because obviously you can't have patient images on your own personal phone unless you've got obviously a system in place.
And just a repeated question about whether the slides will be available, and I have put in the chat, at the end of today's webinar there will be a recording available for you, so we won't be sending out the slides, but there will be a recording, and there will be a feedback form that you need to complete to be able to get a certificate for your CPD, but we'll go through that again at the end of today's session. So I'm going to hand back to Sam so you can meet the coroner in court.
Charlie. So this is just giving you an overview of what the next stage of today's session is. So as the audience, you will play the role of the expert witness and coroner to deliver your findings. So we're going to watch 5 videos, and in between each video, we're just going to have a bit of a discussion and dialogue. So please use the chat function, add any thoughts, any comments in there, and then after each video we'll have a little discussion. Okay, so if my IT is working, this should hopefully play. Because there's quite a lot of people on this call, sometimes there's a lag in the playing of the video and the voice, but you just need to hear it. So it can be a bit distracting because the mouse doesn't go quite in time with the sound, but it's just unfortunate because of the amount of people that are on here that it causes this delay, but just listen.
I am resuming the inquest into the death of Elizabeth Black that was initially opened on the 3rd of April 2022. It is my duty today to listen to the evidence requested in order to assist me in answering 4 questions. Who the deceased is, when, where and how they came by their death. Who, when and where are usually straightforward. It is how they came by their death I need help with. I can confirm that the deceased's full name is Elizabeth Mary Black, but her family have expressed a wish for her to be referred to as Betty throughout this inquest. She was born on the 1st of January 1934 and died on the 31st of March 2022 whilst a resident in Boot Hill Residential Home. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding the death of Betty. I will gather the evidence and based upon that, I will issue a death certificate. Under Rule 42, No verdict shall be framed in such a way as to appear to determine any question of criminal liability or civil liability. Based on the witness statements I have to date, I have taken the decision not to call a jury in this case. I may have to reverse that decision should evidence come to light which would suggest a jury is required. In order to help me today, I have called several witnesses to court and have legal representation for the hospital, for the residential home, and a brief statement from the family. It may be that I cannot actually conclude death due to natural causes, depending on contributing factors and the evidence heard during this inquest, in which case I will form a narrative version. We have heard from the pathologist, who has identified the cause of death as 1A, sepsis, secondary to 1B, infected sacral pressure ulcer with signs of osteomyelitis in the coccyx, 2A, heart failure. Following a fall, Betty was taken to the hospital and was assessed in the accident and emergency department, where she was found to have sustained a fractured femur. Could Miss Brown come to stand? Please, can you confirm your name and your current employment?
My name is Miss Brown, and I am the Deputy Director of Nursing, representing the A&E and orthopaedic wards.
When was Betty admitted and what was she like?
Betty was first seen at the A&E department at 7:30 a.m. following a fall at her residential home during the night.
Was Betty triaged?
No, she had been brought in by ambulance.
Someone must have triaged or received a handover of Betty. How did the ambulance team hand over?
She was handed over to one of the night staff who triaged her. She was then put in reception on a trolley and was assessed by an A&E nurse at 9 a.m.
Why did she wait so long to see a doctor?
The department was very busy. The A&E nurses had numerous ward transfers, analgesia to administer, and overdue observations on 4 patients.
And what happened then?
She was heard to ask for help and was seen by a doctor who sent her for an X-ray, which showed she had a fractured hip.
And how long was she in X-ray?
Approximately 50 minutes, ma'am.
And how long was it in total before she went to the ward?
She waited 8 hours to be admitted to the orthopaedic ward.
Why did it take so long to admit Betty?
There had been an outbreak of norovirus, so some of the wards were closed and the remaining wards were full.
So Betty spent 8 hours in A&E. What was Betty laying on during that time?
An A&E trolley.
Was Betty given any pressure ulcer prevention during that time?
I'm not sure.
Why are you not sure?
I cannot find any records to confirm. I'm sure we tried to turn her, but she was in pain.
Was Betty offered any pain relief?
I will need to consult the notes. Nothing is documented here to say that she had any pain relief.
Can I confirm what you've said? Betty was on a trolley without any pain relief for 8 hours.
According to the notes, yes.
Did anyone ring the family?
No. It was assumed that the residential home would have contacted them.
Do you not think it was important to ring the family?
Yes, but I can understand why, as the department was very busy that morning.
Please can I ask whether Mr. Park, the solicitor representing the hospital, would like to ask any questions?
Yes, thank you. Ms. Brown, is it correct that you were particularly busy that morning as you'd had 2 major road traffic accidents in the night before?
Yes, that's correct. Apart from the normal high volume of patients arriving at A&E, the department was still very busy due to the RTAs, which resulted in serious injuries and one death.
Okay, and since this has occurred, you've put extra procedures in place to help prevent this situation from happening again.
Yes, we now have charts on the wall for each patient detailing their specific needs, especially for pressure ulcer prevention. Also, the trolleys and mattresses have been changed to assist with pressure relief, and we now routinely turn all patients.
No more questions.
Thank you. Can I ask if Mr. Smith, representing the residential home, would like to address the witness?
Miss Brown, were you aware that the residential home rang the family?
No, I wasn't aware. I just assumed they would, as it was one of their residents.
Were you aware the residential home sent a letter about Betty's medication?
Yes, it was in the notes.
Did you send a discharge letter back with her to the home?
Yes, as I said, all patients are sent home with discharge letters and copies posted to their GP.
Were you aware that when Betty came out, there was no discharge letter?
I wasn't aware.
This is not relevant at this time.
I agree. I am.
Sorry, me and IT are not friends.
I
There. So that was our first video. So I'm gonna let you have a minute just to put any thoughts. There's some questions up here you might want to just reflect on. And then in a little bit, I'll go to Charlie and see what you're popping into the chat. And then we can have a bit of a discussion and Charlie can see what's coming through.
Don't be shy. So I thought the role of the legal team was really interesting in that video, Sam, because it seemed to me like they were trying to pass the buck almost. So the hospital solicitor was explaining how they were so busy because of the road traffic accident, and they were short of staff because of the neurovirus in the hospital, and then also mentioned that they'd put charts on the wall for pressure ulcer prevention and a repositioning routine, which was an interesting comment to make.
It's just, I suppose it's trying to show what they've changed within their system. So when we think back to that regulation 28, they're trying to show how they've mitigated risk for future patients and what interventions they've put in. And they just want to sort of showcase, I guess, because no trust wants to have or organisation wants to have a regulation 28 put on them, because it's not a positive thing to have, although it means that you then have to put all those processes in place. If you can avoid getting the regulation 28, it's obviously better for the institute. So I think that's where that questioning sort of comes into place. Interesting you were saying about them trying to highlight all those issues within that service, but there are systems in place, aren't there? If we escalate and we are at a place where we can't care for patients effectively because we've got a breakout of norovirus, you know, we've all seen the pictures of the A&E where the ambulances are queued up round the corner. You know, potentially they could have got the ambulances to defer to another organisation. I know we used to call it Opal in our organisation, and if that happened, I think it was Black Opal, then actually ambulances were deferred. Again, I know that organisations don't like to take that because I think that takes a monetary hit to the organisation. But if you're in a situation where it's unsustainable, the level of patients you're getting and you're not able to give that care, you need to make sure that you're always escalating it to your senior teams. Anything coming through?
Yeah, so we've got quite a few comments. Discharge letter should have been sent with her to the home. Solicitors are establishing facts to enable accurate decisions. Poor documentation regarding the analgesia and the pressure care. The A&E staff should have rang the family to inform them of the new plan. The legal team is to try and provide an excuse to the unit. Department acuity should have been escalated to senior managers and or reported.
Yeah,
That's we've got a quality improvement person on the on the
Brilliant.
call today. That's brilliant. Escalation of the busy department. Was it documented? There was assumptions made. There's absolutely no accountability here. Being busy is the key theme here for what has gone wrong, leading to poor documentation and basic care needs for the patient. The discharge letter has been mentioned several times. Good that they have learned from mistakes, but it shouldn't have happened in the first place. Excuse me. Poor record keeping impacts the case of the care that they've been given. Hospital solicitors setting the scene for the hospital and strengthen what has been changed since this has been put in place. The changes have been put in place, but has training been put in place on them? That's a really good comment, actually.
Yeah.
The realistic pressures within the ED setting are explained well, but the lack of documentation was a big contributor. She was unable to justify or explain this.
And it's the fact that she was on an A&E trolley. So I don't know if any of you have ever had to lay on an A&E trolley, but for 8 hours, I think even I would start getting pressure damage after 8 hours of being on an A&E trolley. I know that some trusts now actually get beds in for patients that are identified at high risk, but then they have to have that assessment and be identified as high risk to then get them on the most appropriate equipment. And you can sort of see where there's lots of missed opportunities already for Betty and the care she's getting so far. So is there anything else? Should we move on, or is there any more bits, Charlie, for this one?
So it was a catalogue of poor events. Poor documentation and record keeping is a highlight, and assumptions that are being made. Some more about the documentation, missing documentation. If it's not documented, it's not been done. Excellent, Caroline. Was the patient reviewed at all during the 8 hours she was on the trolley? We must never assume. Somebody's saying negligence here from the A&E staff. Quite a few people saying that Miss Brown didn't appear to be well prepared. So it makes me think, did the trust actually take it seriously? Somebody saying that the putting in the pressure relieving actions after is like fixing the fence after the horse has bolted.
Yes.
We should never assume anything and ensure we have all the relevant documentation at hand for any investigation. That's an excellent comment, Samantha. Busy workloads really should not be an excuse for poor patient care. Completely agree.
Great comments. Well done, everybody, and thank you, because it really does bring this session much more to life with your great comments. Really good.
I could probably go on for another half an hour, Sam.
Okay. We'll leave that one there and we'll move on to the next video, but please keep the comments coming in, because me and Charlie, we do go back and we read all of them, and sometimes there's new bits that people bring out from these, and it's really interesting to see everybody's views. So we're moving on to part 2 now.
I'd now like to look at what happened when Betty was transferred to the orthopaedic ward. When was Betty admitted?
3:30 p.m.,
And when did she go to theatre?
5 p.m.
What did they do at theatre?
They repaired her fractured hip.
And were there any complications?
No, she came back to the ward and was quite well in herself.
Clearly there are no complaints about theatre. She had uncomplicated surgery and came back to the ward.
That's correct.
Any pressure ulcers when she came back to the ward? When did you start mobilising her?
Betty suffered with slight dementia, so the bed rails were up.
That's not the question I asked you. I asked, when did you start mobilising?
She was not mobilised until 4 days post-op.
Why not?
A physio assessment was required before she could be mobilised safely. However, the on-call physio team was running on skeleton staff and had several chest physio patients to deal with.
Did you get her out of bed at all?
No.
Did you do any pressure ulcer risk assessment before she went to theatre?
No.
Why not?
wasn't time. By the time she arrived on the ward, she was prepped straight away for theatre.
Was there any assessment after surgery?
I will need to check the notes. No, it would appear not.
Why not?
I'm not sure. We must have got her.
Did you put her on any special mattress that might have helped prevent pressure ulcers from developing?
No.
Did you turn her?
Yes. When we washed Betty in the morning and changed her sheets, but not regularly until the Sunday, when we realised she wouldn't have a physio assessment until Tuesday.
Why not?
Each shift, we were expecting her to be assessed, to be mobilised. So we didn't implement a turning regime.
Did you or your team undertake a risk assessment on Betty at any time?
No, not until the pressure ulcer developed on day 4.
When was the pressure ulcer first noted?
We noticed that her bottom became red on the 4th day.
How did you treat the patient?
We applied a dressing to it as it was weeping onto her nightie and bedclothes.
Was it working?
Yes, the dressing appears to have managed the exudate and was changed every 2 days.
Did it deteriorate?
Yes, it did.
Did you reassess Betty?
She would have been reassessed at each dressing change.
When was she sent back to the care home?
She was sent back to the home on the 12th of March.
I have no further questions at this time. Mr. Park, do you wish to ask any further questions?
Yes, thank you. Let me summarize. Your department were extremely busy and short-staffed because of the norovirus. Betty went to theatre and experienced no complications. She didn't fall out of bed because the bed rails were up. And the family seemed very satisfied by their mother's care.
Yes. At no point was any complaint made regarding her care whilst on the ward.
No more questions at this time.
Thank you. Mr. Smith, do you have any further questions?
I have no particular questions about her treatment, but was a discharge letter sent back with her to the home?
Yes, as I said, all patients are sent home with a discharge letter and copies posted to their GP.
So the care home did receive a discharge letter?
I would need to check the notes. It would appear that the letter was left behind and not given to Betty to take home. It is documented the discharge letter would be given to the ward clerk to put in the post.
Point out the discharge letter didn't arrive until 3 weeks later.
I don't know what happened with that.
Whilst I appreciate you were short of staff, the care home were also short of staff. Let me point out how residents don't get pressure ulcers.
This is not relevant at this time.
I agree.
It is quite clear she had a Category 4 pressure ulcer when she left the hospital and returned to the care home, where there was no discharge letter to advise the home of her current condition. Could you ask the district nurses to call?
An answer phone message was left for the district nurses to call at the residential home the next day.
What time was this done?
Approximately 4 p.m. on the day of discharge.
Did you send a letter to the district nurses telling them of her condition?
No. Usually the discharge letter would be passed on to them.
Did you ask the community tissue viability nurse to call?
No, I thought the district nurses would refer to tissue viability once they had assessed her.
No more questions at this time.
We now have a discharge process for all to follow.
Thank you, Mr. Park. Please don't interrupt. You'll have time to offer information prior to summing up on the case.
Okay, so we've got a bit more discussion there, haven't we? A bit more information about Betty and the journey she's on. I'll give you a few more.
We've got loads of
I'll have you.
Yeah.
Okay, I'm going to hand over to Charlie and see what's coming.
So dementia, confusion, bed rails should not be raised. It should have been handed over to the nurse when she went to the ward to check all of the areas. Early mobility was essential by the physio. Every patient should have a body map completed on admission to the ward. As an orthopaedic nurse, we mobilise patients as soon as possible, whether it's elective or trauma, have done since I qualified 10 years ago. Bed rails shouldn't be in place. No skin checks prior to theatre, should be done within 6 hours of admission. No turning or change of position documented. They should have a procedure in place to know how long post-op they should be able to get out of bed if they do this operation regularly. Lack of time, skeleton staff, forgotten to do it, no turning regime, poor patient care, negligence. Bottom red, clearly more than red. If there was exudate, the wound would have been open. Excellent. Pressure areas should have turns in place straight away, not waiting for a mobility assessment. She's shooting herself in the foot. When was skin checks done? Skeleton staff love this phrase, but it's getting to be the norm, sadly. A catalogue of poor practice and neglect. Skin assessment post-op should have been mandatory. There was no mention of a referral to the tissue viability team. Somebody's saying, I wonder what Betty was saying. Was she reporting discomfort, need, want to move? No mention of any escalation. Definitely more than red if there was wound exudate. It should be the assigned nurse's responsibility to check her skin each shift. Surely she would have needed mobilising to use the toilet, or did she have a catheter? And staff need more training on turning regimes if physio assessments are delayed.
And also just thinking, that 4 days of being bedbound potentially sounds like it. The impact it has on that muscle wastage. Betty wasn't able to mobilise before she came into hospital. I know she did have the fall and a fractured neck of femur, but there was a potential to be able to get her back and mobilising. And has that window been lost because of those 4 days? Because it does have such an impact on patients and their ability to mobilise again. The amount of patients I've seen that have come into hospital due to an acute reason, but then have been discharged from hospital unable to mobilise, and that's their future for the rest of their life. So just thinking about that impact on quality of life again. Any more, Charlie?
Poor staffing, no risk assessments, turned once a day, no measuring of the size of the pressure ulcer or what stage it was.
Or photography.
Was an electronic referral done to the TVN or DN, not just a phone call? Risk assessment should have been conducted.
Brilliant.
Uncomplicated surgery, bed rails with reason, dementia. 4 days until physio assessment, no skin integrity and water flow assessments at all. Noticed on the 4th day, dressing changed every 2 days. Discharge letter wasn't given to the care home, nor to the district nurses or TVN. No referrals done. They're passing the buck. Leaving a voicemail for the district nurses is not acceptable. Poor nursing care. No evidence of duty of candour at this point.
Yeah, and that sort of relates back to the hospital solicitor saying so she had a good theatre operation, there was no complaints, but were the family actually aware that Betty had sustained this damage? Had they done duty of candour? And is that maybe why they didn't get any complaints or concerns, because they just weren't aware and not having that open and transparent conversation?
Query mild dementia. I wonder if this had been a formal diagnosis or the development of a delirium, which could have been due to the potential infection that was brewing there. I could keep really going, good. Sam.
Really good. Well done, everybody. Great. Obviously, this photo, we've discussed in a bit of depth about the categorization. So it's not about categorizing, but it's actually just reflecting on your practice. If you were presented with this patient with these pressure ulcers, it's how would you document those? Because you've got multiple areas there. And it's just thinking how you would document that. You've got some deep tissue injuries. You've got category 1 potentially on the heel because you've got that erythema. Is it blanching? Is it not? And just making sure that you are able to document every single one of those wounds accurately so that you can evidence what you've done. And it's not only just the categorizing, it's the interventions you put in to prevent further deterioration. So it's getting those offloading boots. It's how often are they going to be repositioned? How often are you going to check that skin? And that's just to state that with this photo. So we're going to move on to the next video, unless there's anything else, Charlie.
No,
We'll go on. So video 3. I sound so old when I say video. Clip 3. I am of an age.
Not everyone will know what a video is on here.
Can Mr. White come to the stand? Can you confirm your name and your current employment?
I'm Mr. White, and I'm the manager of the residential home.
You are one of the senior nurses?
No, I'm the manager, but not a registered nurse.
How long have you worked there?
For approximately 10 years.
You know your residents well?
Oh, yes. I work predominantly days, so I get to spend a great deal of time with all my residents.
Now, can I first of all ask you to run through Betty's situation?
Yes, Betty was found on the floor during the night between the commode and the bed.
Did Betty have bed rails up?
No, Betty was quite independent with her frame and could get out of bed herself. She had been doing this for the past 5 years. Her family knew that she could quite safely potter around the home and would have her buzzer if she wanted us.
And is it correct that she was found at 6:15 a.m. in the morning?
Yes. One of the carers found her whilst doing his hourly rounds.
When was she last seen?
According to the carer, he went round at 4 a.m. and looked in on Betty, who was fast asleep in bed.
Did Betty normally go to the toilet during the night?
Yes. She had her buzzer, but would normally use her commode herself and would only ring the buzzer if she wanted a cup of tea.
Had she rung the buzzer that particular evening?
No, on this particular evening, she had slept very well.
And did you hear any noise at all?
No, nothing. The carer just popped his head in that morning to check on her, as he would normally do.
And what did he find?
He found Betty on the floor between the commode and the bed. She didn't have a Zimmer frame with her this time.
Was Betty able to tell you what had happened?
Not really. She was, well, how shall I say? She was a happy but confused lady. She said she'd fallen, but the carer said she'd wet herself, so we assumed that she'd fallen trying to get to her commode.
And what did the carer do?
He pressed the emergency buzzer and called the senior carer on duty, who decided to call an ambulance as Betty's leg appeared to be shortened. She also appeared to be in a lot of pain, so the carers didn't want to move her.
And Betty was taken to hospital?
Yes, the paramedics arrived, gave her some pain relief, and took her to hospital.
And how long did it take?
They came within 20 minutes. Paramedic arrived initially, followed by a 2-man ambulance crew. They made her as comfortable as possible and then took Betty to hospital.
Okay. So just let you have a bit of time just to have a look at those questions if you want to answer those in the chat, or just any thoughts or comments.
Where was he at 5 a.m.
Yeah.
if he does hourly rounds?
Well spotted.
If
Yeah.
Betty could get out of bed and walk around, she wouldn't have a pressure sore. 4 a.m. to 6:15, that's not an hourly round. This evidence was before the fall and pressure damage. Pressure also could have been developing in the 20 minutes while she was laying on the floor waiting
There's
for the
a
ambulance.
there's a potential, isn't there, that if she fell at just after 4, that she was laying on the floor for 2 hours
Yeah.
in wet because she was incontinent as
Yeah.
well. So that could have been the starting point of it all.
Whereabouts was her frame? Was it within reach? Lapsing checks. Why did she not have her frame? She was on the floor approximately 3 to 4 hours by the time she actually got into the ambulance.
Yeah. And then she had a further 8 hours on a hospital trolley.
Mm-hmm.
So
If she had a buzzer, why was there a commode in the room? Good question. Potential unsafe staffing levels at the time, staff taking breaks, resulting in lack of checking, as should be. If she normally wakes at a certain time each night, you would be worried about her not waking, may not have had her buzzer.
And it could be that this all started just because maybe her Zimmer frame was out of reach.
Yeah.
And the consequence of that on this patient's journey, just for that one element that could have changed. It's like that sliding doors film, isn't it, where it could have gone two ways, and the different journeys. Or when you think about the NHS Betty story, the two outcomes, the optimal care and the suboptimal care.
Someone's put fantastic account of events from the manager. I think he justified things well. Documentation was needed to state why they didn't check her skin while awaiting for the ambulance. Assumption that Betty was trying to get to the commode, unknown time on the floor. Was she known to have falls? Did they ask her where her pain was? May have helped to determine if potential pressure ulcer or anything else was developing. If there's a discrepancy with the hourly checks, were the levels checked in case of a long lie? CK levels, sorry. We cannot say she was on the floor for 3 to 4 hours. We're assuming, which is dangerous. There's been assumptions made by the home. Did she have a falls risk assessment completed? And was that followed? Her nutrition and hydration could have been compromised. Probably already sustained the pressure damage while on the floor. Should have been already red flag for pressure harm by ambulance service and A&E. Was the room lighting appropriate for her to be able to see? Was the commode in the normal place of where it usually is? Why didn't anyone contact her next of kin? Why did no one hear her when she fell? What does the hourly check include? That's a good question, because quite often it's just a peek through the door to check that they're still in bed.
A good question. Whose responsibility is it to contact the family? Who would you assume the responsibility lies with? Just see what people write to that. Is it the care home? Is it the hospital? Or is it everyone's responsibility?
Both. Care home, both.
Yeah.
Everyone's.
Everyone's.
Absolutely.
Yeah.
Both. Most people saying both.
Yeah, absolutely. And you know, it's much, as a family member, you'd rather be called twice or 3 times than not have any phone call at all. So yeah, I think that's good. Anything else before we move on to?
Just there's a couple of comments about the I'm not sure on the right terminology, like the movement mats.
Oh, the sensory, they buzz, don't they? They buzz when you move.
If she'd had previous falls, perhaps, you know, one of them might have stopped this from happening. Yeah, fab. Brilliant, right. Everyone. Keep it coming.
Okay. Clip 4.
Now, I want to talk to you about when Betty came out of hospital. What was she like when she came back to the home?
She wasn't mobilizing, so we had to hoist her onto the bed, and she had a dressing on her bottom that was dirty and soiled in places.
Did you receive a discharge letter?
No, there was no discharge letter. I contacted the hospital ward to get information.
Was she sent home with any medication? Was there any information regarding this from the hospital?
No, nothing. After speaking to the hospital, we found out that she was on the same medication she was on prior to her admission. So we had everything here.
So Betty just arrived in an ambulance from the hospital?
Yes.
As you had no information, what did you do?
We rang the district nurses, who said it would be Wednesday or Thursday before somebody could visit to assess Betty, as they had no availability for extra visits.
Did you tell them how bad the ulcer was on Betty's bottom?
No. At this stage, all we knew was that she had a dressing on her bottom that needed assessing and changing. We are only a residential home, so we can't do those things.
How did you cope with Betty's needs?
With difficulty. We're not qualified nurses. We are a care home who rely on the local district nurses for nursing support. We didn't have all the relevant equipment ready for Betty when they sent her home.
What did you do?
Betty needed nursing care. So I rang the district nurses again. We couldn't wait. We didn't have any dressings available, and Betty's dressing really needed changing.
Did you speak with anyone?
I left an answer machine message. The district nurse did phone back the following day. But in the meantime, we put her back on her old medication and put on a dressing from another resident, as we had to make her clean and comfortable. We also gave her a good wash, as she looked dirty, and cut her fingernails, which had grown so long and were dirty underneath. What Betty liked best of all was a good cup of tea. She was so thrilled to see us, as we were faces that she knew. She was a lovely lady, and we loved talking to her. A bit confused at times, but we loved having her around.
What happened with Betty over the next few days?
The district nurse called to see her and was appalled at the state she was in. She'd never seen anything like it and didn't know how the hospital could send her out like that. We are only a care home, but we were just left to cope. The GP also called after 2 days and prescribed some antibiotics. The district nurse changed the dressing, but poor Betty was so poorly she just went downhill.
What do you mean she went downhill?
She seemed to lose the will to live, stopped eating, would still drink, but she lost her spark. Betty's wounds started to smell, which upset her, and she wasn't able to get in and out of bed herself, and would ring the bell if she needed the toilets, but would sometimes soil herself before we got there. It was painful for Betty to move and sit up in bed due to the pressure ulcer, and then she developed a chesty cough, so we rang the GP. She begged us and the GP not to send her back to that hospital. And John, her son, asked if we would keep her at the home and care for her there. Although we're only a care home, we couldn't send her back to that hospital. Sadly, Betty died a few days later. We cared for her and were with her when she passed on. She seemed to be at peace.
I have no further questions at this time. Can I ask Mr. Park, representing the hospital, if he has any questions?
Okay, so I'll come over to Charlie.
We've got lots and lots of comments here. So no discharge letter, no clear plan for the dressing or what the wound looked like on discharge. So it's difficult to know if that wound had worsened. Shouldn't accept a patient without a discharge summary. Should have had a transfer letter as well as a discharge letter. Unsafe discharge. Should have the district nurse in place before going home. Failed discharge, unsafe discharge, put the home in a very difficult position, and the care she needed was outside the home's expertise. They could have not taken her back had they known. Was there not a handover given to the home verbally? Why could they not check her skin integrity if they are her legal guardians? Very safe hospital discharge. Staff were forced to work outside their expertise. Unsafe discharge to an inappropriate care setting that does not meet Betty's new care needs. The referral to the district nurses should have been sent by the hospital. I think this is becoming a major problem between hospitals and district nurses. Hospital discharge and don't speak to DNs to check when they'll be able to visit.
And there's also, you have got discharge teams, haven't you? And I know that when I worked in the hospital, we often had the home staff come in to see a patient prior to discharge to go through and see whether they had the capacity and the right skills to bring people back. So there are better teams around that can be involved with this, like the discharge coordinators, to make sure that transition is correct. And often I think sometimes in hospitals it's that language again. Do they think that they're referring back to when they say care home, do they assume that there's going to be nurses there? are they aware of the actual the setting that they're sending patients back to?
So one of the comments here is Miss D. I'm not sure about other areas, but if we have patients from a care home, the care homes have to do an assessment before they can go back, which in my opinion is a good thing. An actual face-to-face discussion.
Yeah,
absolutely. Hospitals should have checked that the care home had suitable equipment in place to take care of the patient. She wasn't safe to be discharged home. This is what happens when money is over care. So sad that she was discharged like that. Poor handover from the hospital. They should have discussed it with the care home prior to her discharge, and they may have the opportunity to discuss her care. Unfortunately, an all too common occurrence. Hospitals should arrange the DM referral.
Yeah.
And I could go on and on and on.
Mm-hmm. Another interesting one, I think you discussed it earlier, Charlie, was about that power of attorney and the being able to make that decision on, because Betty didn't want to go back into the hospital, did she?
Yeah.
And I can't quite remember what you said. You were saying about it this morning.
So we did the session this morning. We're repeating it this afternoon, and what we discussed this morning was around the fact that somebody highlighted that did she have capacity? Did she have the capacity to make the decision not to go back into the hospital? Did the family have
power of attorney
over health and well-being to be able to make that decision for her? Was the GP involved with that decision, or had she actually completed a respect form when she did have capacity? Or was a respect form completed in the best interests of the patient by the GP to say that it wasn't in her best interest to go back into hospital? So lots of things to think about. Somebody just saying, does she have an advanced care plan?
Yeah. Brilliant. Well, you're doing very, very well. And the other thing I just wanted to put out there was that actually we know that Betty passed away, but she actually, was it better for her, and I'm just throwing it out there, for her to pass away in a setting that she was aware of, with people who knew her surrounding her? Because what would the other option be? That potentially she went back into hospital and she was on a ward with very little staff and potentially passed away with a curtain pulled around her.
Mm-hmm.
And I'm just throwing it out there as sometimes you have to play devil's advocate.
Yeah, we've got some thumbs up and people saying better to be in her own environment, as she's been there for 5 years. It's much better for her. But nurses' hospice care should have been involved to make her comfortable. She knew the people that were in the nursing home, and definitely better as long as there was adequate support for pain relief and palliative symptoms. Absolutely.
And obviously the best outcome would have been that she didn't go on this journey, and it had a different outcome anyway. But it's just another thing to think about, isn't it? For Betty.
Mm-hmm.
Right. We ready to move on, Charlie?
Yep.
Yeah. So we're on to our last clip, and then you get to have a think about what you would draw as your conclusion. So this is the last one.
Thank you, Mum. Betty had a fall at your home, did she not?
Yes, she had a fall, tried to get to her commode.
Did she not need nursing care to help her to the toilet?
No, for the last 5 years, she had been going to the toilet independently and would only use the commode at night, so she didn't have to walk too far soon after waking. All of our residents have quarterly risk assessments as standard, unless their needs change drastically in that time.
The nurse on the ward rang your home and you said you were prepared to accept Betty back.
But she didn't tell us that she had a huge pressure ulcer. She didn't tell us that she'd lost her mobility. She just said that she'd had her surgery, was fit for discharge, and asked if we were prepared to accept her back. We always take our residents back.
No more questions.
Mr. Smith, do you have any questions?
Yes, thank you. Can I just make it clear there was no discharge letter?
No, there wasn't.
Called the district nurses?
Yes, 2 or 3 times.
Called the GP.
Yes, with the district nurses when they visited due to their concerns.
Can you just explain to the learned coroner what type of patients you take?
We are a residential home, and all of our residents are assessed prior to coming in on their ability to perform normal activities. Most of our residents can mobilize with a frame or at least transfer themselves. We have 1 or 2 who require a hoist, but as long as they don't have nursing needs, we can accept them. If they do need nursing care, we work in partnership with the district nurses, and as long as they are happy and can support, we are also happy.
Do you have any qualified nurses?
No, sir, we do not.
No more questions.
Thank you, Mr. White. I now have a short statement to read from the family. John and the rest of the family would like to express their gratitude to all at Boot Hill Residential Home for all they did for his mother, Betty. They were very pleased you were able to keep her there and care for her, surrounded by people she knew and trusted in her last few weeks of life. Can I now ask Nurse Spears to come to the stand? Can you please confirm your name and current employment?
I'm Nurse Spears, a district nurse.
Have you been to Boot Hill Residential Home before?
Yes. We visit twice a week to provide a service for patients that require nursing care, such as catheter maintenance, insulin injections, change leg ulcer dressings.
Did you get notification from the hospital about Betty?
Yes. A message was left on our answer machine informing us that Betty had been discharged.
What information were you given?
Just that Betty had been discharged and that we would need to assess her.
Did the residential home ring you?
Yes, one of the carers left a message for us asking for urgent help.
Then why did you say you'd go in 2 to 3 days?
The care home didn't indicate why it was urgent on the phone, nor did we receive an urgent referral from them.
Did you get a second phone call?
Yes.
What did you find when you got to the home?
I was so shocked. I haven't seen anything like it for years. It was a huge sacral pressure ulcer. You could see the bone.
How would you grade it?
Category 4. We call them categories now.
Was the wound infected?
Yes. It was showing all the clinical signs of infection. We spoke to the GP who visited and said she needed antibiotics.
Think she was fit to come back to the residential home?
Not at all.
Why not?
Betty would have been fine to have been discharged with the appropriate discharge plan in place. That would have given everyone enough time to have provided the appropriate resources, such as mattresses, appropriate dressings, and support for the home so that Betty could be safely discharged back into their care.
Why did you not readmit her?
I cannot admit someone to hospital. I have to do that via the GP. The family and Betty didn't want her to go back into hospital, though. They were adamant. The residential home were happy to keep her with our support.
Did you arrange for some dressings?
Yes.
And who was going to change them?
One of our district nursing team was to call every day.
They call every day? Did you not hear my question?
Unfortunately, no. The district nurse did not call every day.
Why not?
Well, one weekend, I left a message on the handover phone for the weekend team to visit, but no one picked it up, so she didn't get a visit on that Saturday.
Did Betty's pressure ulcer start to heal?
No.
Why do you think it didn't get any better?
It was so bad when she came back to the home. Due to her reduced mobility, she had grown incontinent. Her skin was so delicate, and her general condition deteriorated very rapidly.
This is a residential home.
Yes.
Did you arrange for a pressure-relieving mattress?
We advised regular turning initially.
That was not the question I asked you.
It was on order.
Did it arrive?
Not before she died.
Who should have ordered this so that it would have been there in time?
If the hospital had given us enough notice, we could have had all of this in place ready for discharge.
Did you receive a discharge letter?
No, it actually arrived 2 weeks after Betty had died.
Was a referral made to anyone else?
No,
Why not?
I would have expected the hospital to have done that.
But surely, as the district nurse, wouldn't you request it?
Well, no. The hospital requests the district nursing team to visit. I would have requested them to have asked for the TVN referral if I had been aware of the situation.
Thank you. Mr. Park, do you have any questions for the witness?
Yes, thank you. When did you receive the hospital message about Betty's discharge?
As it was after 4 p.m., we didn't pick it up until the following morning. It didn't mention that Betty was ill or that she needed an urgent visit, just that she had been discharged from the ward and that we would need to make an assessment.
Do you see many pressure ulcers in the community?
We see a few pressure ulcers from time to time, but over the years that has greatly improved through education and training, especially in residential and nursing homes.
Thank you. No more questions.
Thank you. Mr. Smith, do you have any further questions?
Yes, thank you. Can I clarify that the residential home rang you and asked for an urgent visit and it was your decision not to do so?
Yes,
Can I also clarify that you called the GP and that he had already been called by the residential home?
yes,
Can I clarify that you did not receive the discharge letter, nor did the residential home?
yes, that's right.
Thank you. No more questions.
Thank you.
Okay. Charlie, many comments?
Yeah,
Things
quite-
come through?
Quite a few. We send first dressings on discharge, poor escalation from the residential home to the district nursing service. If it was an urgent call, the DNs aren't an urgent service. Urgent would be via 111 or 999. Care homes should check her skin on admission. Insulin twice a week
I
with
know.
a laughing face. I'm glad you picked it up. It always
Yeah.
makes us chuckle too. We just put that in there to make sure that you are actually listening, you see. There's been a lot of a lack of communication between all areas that have been involved.
Again, there's lack of communication because the district nurse leaving a handover message. And I'm sure most of you were too young to remember, but when I first went into community, we used to have a sort of communication book and a phone
Yeah.
that was the team one. So
A few people saying they still do
oh, they do, yeah.
referrals.
And things do get missed, but I think that's why we've developed these new systems and why things happen, because we need to tighten up these processes, because, you know, at the end of the day, we're all human and, you know, we can't help, there is going to be human error somewhere along the line, but we just need to try and mitigate it as much as possible.
Thank you, Jen. DN here. We can get same day delivery of pressure relieving mattresses. Sounds like the discharge pathway needs to be looked at to safety net the process.
Yeah.
Unsafe discharge, poor communication. The hospital failed Betty. They should have made sure everything was in place before she was discharged. All nurse to nurse communications should have been completed. DN should have asked why the home thought it was urgent. Hospital failed this lady. I don't think it was a poor escalation from the care home. I think the hospital sent the patient home with too great a need, and the DNs chose not to review as urgent as they were asked to. Care home should have clarified her needs on the call from the hospital, though.
A lot of it is that communication, isn't it? And I think often, you know, that was in most incidents, whatever it's relating to, there is always an element of communication where it's somewhere along the line has gone awry and things have happened.
Some people saying that in their trust they have 3 copies of the discharge letter. One goes with the patient, one gets faxed or emailed to the GP, and one stays in the notes. So if nobody receives it, they've still got a copy of it in the hospital
To then
be able
resend,
to
yeah.
resend or give the information over the telephone. A few people saying that they do that too.
Good.
Yeah, some really, really good comments from you all. Thank you.
Brilliant. Thank you so much. And it really does bring this session to life. So now it's your turn to take on the role of the expert witness. And when I'll put up the slide with the possible verdicts or conclusions, and if you just pop in the chat what you feel the outcome of Betty's case would be if you were the coroner, what verdict or conclusion would you come to out of these 6?
Oh, they're piling in,
Are they?
The majority of people are saying neglect. A couple have said narrative.
Yeah,
mostly neglect that is coming through at the moment. Narrative.
So we've got a mixture of neglect and narrative, but the higher proportions
Is
going
neglect.
with the neglect.
Yeah.
So the actual
corporate manslaughter, someone's just put. That's
so,
not on the slide.
but there is manslaughter, unlawful killing. So the actual outcome for this Betty's story is actually a narrative. So the coroner sets out the circumstances of the death in a detailed way based on the evidence heard. And it's often a discussion we have great depth in whenever I do this session, because to understand why it wouldn't be neglect. And it's because the basic needs have been met for Betty. So she's had food, water, those basic needs have been met, although there has been a multitude of areas where she's been let down. So that is why that conclusion would be a narrative. Anything else coming through?
Wonder what the CQC did.
Yeah.
Someone put, tell that to Betty.
Yeah.
The majority of people here have put neglect.
Yeah. So then if you can remember when I was going through that regulation 28, so do you think that this would have had a regulation 28 as the coroner? Do you think that you have got enough confidence that things have been put in place to mitigate this risk happening to another patient?
Yes. Massive learning needs actioned immediately. Lots of people, somebody did question, is basic skin integrity not neglect if it's not carried out? I think I'm not sure that basic skin integrity falls under the basic nursing. That's a nursing care, yeah.
Whereas actually when you're thinking of those basic needs, I think I always think about that. There was a report in the paper, wasn't there, of a patient that had said that he's not been given a drink for 3 days or something, and was that's where those basic needs are not being met. That growth
to keep you alive.
Yeah.
That your basic needs, so food, fluids, warmth are your basic needs. But everyone coming through is saying that there should be regulation 28. There was lots of learning opportunities here, reflection and change of practice, that the code is to do no harm, absolutely. Is comfort not a basic need?
And I think the thing is, as a coroner, if I just heard all that, am I satisfied that another patient going in would not have that same care, even though they've done a few things within that A&E department? I think I would be concerned, especially with that discharge process, that it could be some further issues. So I can understand why you would feel that a regulation 28 should have been
but they did put a discharge process in place, didn't they? The solicitor did say. Because he interrupted from the hospital.
From the
hospital.
Okay.
A discharge process put in place.
So they have mitigated that regulation 28 through those changes they've made. So I think that, oh, what's happened?
Sorry. This case sounds like it's come from 100 years ago. We've moved on so much since then. This was unavoidable, surely. I'm sad to say that actually this still happens on a daily basis.
And I think when I've read earlier that case that was only last year,
yeah,
where you've got a patient that has not had all those risk assessments carried out, hadn't had skin checks, hadn't been repositioned for 22.5 hours each day. I do agree there are some elements where it has improved in some areas, but there's still, there's still phone call messages being left. There's still paper discharge letters being taken out. So I think that although things have got a lot better, and in some areas they may be much more ahead of the curve, there are still a multitude of places where this is still happening.
Yeah. It's all about money now. Care equals business. Sadly, I think there is some truth in that. The communication between acute and primary care is very poor, and I would agree, and that's something that we all need to work on, is improving that communication between the different agencies, because ultimately we're all there for the same thing, for the patient at the end of it. So we've got a responsibility as well to improve that communication.
Okay, so thank you everybody for your contributions today. I hope you've got some bits to take back to your practice and to reflect on, thinking back to our importance of our documentation. If you didn't record it, it didn't happen. Just, next time you're writing your notes, think, is there anything else you could do to improve that documentation, to make it more concise, to give that rationale of the care you're giving. I've just put a QR code up, and that's the evaluation form. So if you're able to scan it and complete the form, and then you'll get sent your certificates, and you will get your link for the recording of this session.
If you don't fill the evaluation form out, there will not be the certificate, and the recording doesn't get sent. So we need you to fill this out to enable you to get your certificate, so that you can have it for your CPD. So please do make sure you scan the QR code or use the link to be able to fill out that form, please. Got lots of thank yous coming through, Sam.
Brilliant. While you're filling that out, and we've got a few minutes, I just wanted to share with you that we have our Coloplast Professionals web page, and if you access that, we do many webinars. We've got obviously the Coroners Court webinar that you've attended today, but we also do other webinars looking at wound infection, leg ulcers, all sorts of subjects and topics. And if you go on there, you can register to attend other webinars whilst we're looking at our 3-step approach, which is assess. So completing that really good holistic assessment of your patient, your wound, your wound bed, wound edge and peri-wound skin, and then preparing your wounds using all prep pad, and then treating your wounds with 3D fit silicone dressing. So please do access that if you're interested in coming to any more of our webinars. We've also got Charlie and I, we do a podcast, so you can access that on wherever you access your podcasts, Spotify, Audible, whatever your platforms are, and just look up Wound Care Conversations, and you can listen to Charlie and I talking. And we also have some guests that come on, and they're just quite good if you're driving around or have a few minutes to spare. What else can I let them know while we've got?
People just asking if there'll be further Coroners Court sessions. We will do further Coroners Courts. There's some planned for June in Legs Matter Week next year. There'll be 2 again, and if you have a look on Coloplast Professional, you should be able to book onto those. We do face-to-face events with local NHS trusts that we're working with, so do keep an eye out. If your trust has biotin silicone and all prep pad on their formulary, then it's likely that we will be doing a face-to-face Coroners Court in your area, so do keep an eye out for that. Everyone's saying thank you, Sam, and it's been really good and quite eye-opening. People asking for the slides. We don't send the slides out. If you fill out the QR code or the link that I've put in the chat, you will get sent your certificate, and we will send you a copy of the recording, but we don't send the slides out. So you will get a copy of the recording, and you will get your certificates.
Have you put the QR code in the chat?
I haven't got.
Oh, okay. I'll just leave it up.
I've put the link in.
Oh, brilliant. I'm just going to stop sharing, and I can actually see.
So I've got somebody that's got their hand up. Is it Akpan? Do you want to speak?
Somebody got any question? Yeah.
You want to turn your microphone on?
Sarah, can you use your microphone now?
Hello, hi.
Ah, hello.
Oh, sorry, I couldn't click on the link. It didn't do anything. I was clicking on the link, but it didn't open. Pardon?
I said, oh, I'm not gonna know how to fix that. So I think Charlie's going to take a look at it.
Okay, thank you.
Just having
I think a couple of people have put it in the chat now, and I've just clicked on one of the links someone else has put in, and it brings it up.
Right, it's just my end then. Could we go back to the link and I'll try again?
Oh, what? Put the screen back up?
Yeah, because I was clicking on it, but it wouldn't open. Thank you.
If you go through the chat, somebody called Daniel has put it in, and so has Ben Meadows. So if you click on some of them links,
yeah, lovely.
Yeah.
Many thanks.
If that works for you. If the link was on the screen, you wouldn't be able to open it, but in the chat you will be able to access it. Yeah. And then we've got somebody else has got their hand up. Follow Shade. Sorry if I've pronounced that wrong. Do you want to come on and speak to us? No. Somebody just asking if we can explain the new classification. Do you mean the classification of pressure ulcers, Melanie? Yes, please. So, the National Wound Care Strategy brought out their guidance on pressure ulcers last year, and instead of having the 6 categories, which would have included category 1, 2, 3, and 4, unstageable and deep tissue injury, they now just have 4 categories, which are the category 1, 2, 3, and 4. Unstageable falls into category 3 until the slough and devitalized tissue has been removed from the wound bed and then recategorized if it needs to be. It may stay as a category 3, it may go to a category 4. But it's very much dependent on what your trust, your area has decided to do, because not everybody has adopted that. Some areas have kept unstageable and deep tissue injury. Some have just kept the deep tissue injury along with the 4 others. So make sure you follow whatever guidance is in your area. Somebody also asking what our podcast is called. It is called Wound Care Conversations. I can pop it in the chat for you. I'm just checking there's no more questions. Ben is our digital marketing manager. He is brilliant at what he does, and he's popped the podcast link in the chat for us. I'm just going through. There's so many of you, but just make sure you've all filled out the either clicked on the link or scanned the QR code so that we can ensure that you get your certificates. I think we are. I think we're about there.
Yeah. So thank you again, everybody, for coming today, and thank you for your great comments and your interactive. It really does make this session so much fun. So thank you very much, and hopefully you can either get back home if your shift's finished, or hopefully you won't have too much longer to work, but maybe see you at another webinar.
Yes. Thanks very much.
Take care. Bye.